Next, we'll move on to special tests of the elbow, and these are divided according to the underlying pathology. To test for valgus stability or UCL injury, the milking maneuver and the moving valgus stress test are recommended by JOS. The milking maneuver tests the integrity of the anterior bundle of the MUCL. This attempts to simulate the position of stress in a throwing athlete. With the affected elbow flexed to 90 degrees, the examiner pulls on the patient's thumb with the patient's forearm supinated, the shoulder forward flexed, and the elbow flexed past 90 degrees. This test is considered positive if the patient experiences subjective feeling of apprehension and instability along with medial elbow pain. This sensitivity has been reported as 87.5% with a negative predictive value of 100%. The moving valgus stress test is used to assess the integrity of the anterior bundle of the MUCL as well. Doing this test in its static form can be difficult, and subtle laxity may be too small to detect on examination. In an effort to produce a more sensitive test, O'Driscoll et al. Described this movement called the moving valgus stress test. With the patient seated or standing, the shoulder is abducted to 90 degrees and the elbow maximally flexed as modest valgus stress is applied to the elbow with the shoulder externally rotated to its limit. While maintaining constant valgus stress, the elbow is quickly extended to 30 degrees. A positive test must generate the pain that is experienced by the patient with aggravating activities, and the patient should experience maximal pain between 120 degrees, which is equal to late cocking, and 70 degrees, which is equal to early acceleration in the stages of throwing. Sensitivity of this test has been reported as 100% with a specificity of 75%. When testing for epicondylitis, there are different examination maneuvers for medial and lateral pathologies. Starting with lateral epicondylitis, the Maudsley test is resisted middle finger extension, which selectively recruits the ECRB tendon and can reproduce symptoms of lateral epicondylitis, but of note, this may also be painful in radial tunnel syndrome. Resisted wrist extension with elbow in full extension and pronation stretches the common extensor origin and may also recreate the symptoms of lateral epicondylitis. The chair test is when the patient is asked to lift a chair with the shoulder forward flexed, the elbow extended, and the forearm pronated, and is positive if the maneuver provokes lateral elbow pain and indicates lateral epicondylitis. For medial epicondylitis, the test is aptly named as the medial epicondylitis test. The patient's elbow is fully extended, and the examiner resists the patient's wrist flexion and forearm pronation. Medial epicondylitis is likely if the patient experiences pain over the medial epicondyle with these maneuvers. For triceps rupture, you can use a modification of the Thompson test that is used for Achilles tendon rupture. The patient's upper arm is placed on a table with the patient prone and the forearm hanging freely over the edge of the table. The examiner manually squeezes the triceps muscle belly while the patient's arm is relaxed. If the triceps tendon is intact, the elbow should slightly extend. For posterior lateral rotary instability, you can use the lateral pivot shift test and the posterior lateral rotary drawer test, as well as 3 more tests described on the next slide. The lateral pivot shift test can be performed in an awake or an anesthetized patient. The patient is positioned supine with the affected extremity raised over the patient's head, the shoulder fully externally rotated, and the forearm fully supinated. The examiner grasps the patient's wrist or forearm and, starting with a position of full extension, slowly flexes the elbow while applying valgus and supination moments along with axial compression. At approximately 40 degrees of flexion, rotary displacement is maximized, and the patient may demonstrate apprehension and pain. Positive result in the anesthetized patient will demonstrate a palpable and visible clunk along with posterior dimple, and associated dimple proximal to the radial head representing the dislocated radial humeral ulnar joint. With further flexion, a clunk will occur when the joint is reduced. Posterior lateral rotary drawer test starts with the elbow in 40 degrees of flexion, and an anterior to posterior force is applied on the lateral aspect of the proximal radius and ulna in an attempt to translate the forearm away from the humerus on the lateral side, pivoting about the medial ligaments. Positive test is indicated by apprehension or the presence of a skin dimple. The next three tests, the prone push-up test, the chair push-up test, and the table relocation test, are also widely described. The prone push-up test involves the patient positioned prone on the floor with the elbows flexed at 90 degrees, the forearms supinated, and the arms should be abducted to greater than the shoulder width. The patient is then asked to perform an active push-up. This test is positive if apprehension and guarding occur as the affected elbow is terminally extended from a flexed position. The chair push-up test begins with the patient seated in the chair with the elbows flexed at 90 degrees, forearms supinated, and the arms again abducted to greater than shoulders width. Patient is asked to push up from the chair using only upper extremity forces, and this test is positive when the patient demonstrates apprehension while extending the elbow or as he or she raises his or her body from the chair. Tabletop relocation test comprises three parts. First, the patient is asked to stand in front of a table with the hand of the symptomatic extremity placed around the outer edge of the table. The patient is asked to perform a press-up maneuver with the elbow position pointing laterally, maintaining the forearm in supination. The patient is then asked to push down through the hand onto the edge of the table, allowing the elbow to flex while bringing the chest toward the table. This is positive if pain and apprehension occur at approximately 40 degrees of flexion. Next, we're going to repeat the maneuver with the examiner's thumb over the radial head, and symptoms of pain and instability should be relieved as the thumb prevents subluxation of the radial head posteriorly. Finally, the supportive thumb will be removed during mid-elbow flexion while repeating the maneuver a third time, and pain and apprehension will return. A positive test should be pain in the first and third portions of this maneuver and relief of symptoms in the second portion. For radiocapitellar joint pathology, one can perform the radiocapitellar compression test. This involves the examiner bringing the patient's forearm through a passive range of forearm pronation and supination at the mid-range of elbow flexion while applying an axial load to the radiocapitellar joint. Crepitus or pain with axial loading represents a positive test, and this may indicate an OCD lesion or radiocapitellar joint chondrosis. For biceps rupture, we have the hook test and the bicep squeeze. The hook test involves asking the patient to actively flex their elbow to 90 degrees and fully supinate the forearm. The examiner then attempts to hook the biceps tendon with the finger from the lateral side of the antecubital fossa beneath the lateral edge of the biceps tendon. If the tendon is intact, the finger can be inserted approximately 1 centimeter into the tendon insertion. If the biceps tendon can be hooked but elicits a painful response, this may suggest a partial tear. If the biceps tendon cannot be hooked, this suggests a full tear. The biceps squeeze test is again analogous to the Thompson test for the Achilles. The elbow is flexed to 70 degrees and pronated, and the bulk of the biceps is squeezed with both hands by the examiner. A positive test would be lack of forearm supination, and this sensitivity has been reported at 96% with unreliable sensitivity. The biceps crease interval and passive forearm pronation test can also be used to evaluate biceps tendon rupture. Biceps crease interval is performed by bringing the patient's elbow from flexion into full extension and marking the main flexion crease. The contour of the distal biceps is lightly palpated back and forth along the line, parallel to its long axis, to identify the point at which the curve of the distal biceps begins to turn most sharply toward the antecubital fossa. This cusp is also marked with a transverse line, and the distance between the two lines is measured. The contralateral unaffected arm is also measured to calculate a biceps crease ratio. A positive test is an increasing distance from greater than 6 centimeters or a biceps crease interval ratio greater than 1.2. Passive forearm pronation test is based on the observation that the biceps muscle belly moves proximally with forearm supination and distally with pronation. The examiner moves the patient's forearm through a passive range of motion through supination and pronation and uses palpation and visualization to assess for appropriate movement. When the hook test, the BCI, and the PFP are taken together, sensitivity and specificity have been reported as high as 100%. Last are the tests for compressive neuropathies of the elbow. For ulnar neuritis or cubital tunnel syndrome, you can use Tinel's sign, which involves tapping along the ulnar nerve distribution, or the prolonged elbow flexion, and both of these tests should recreate paresthesias that the patient experiences. For proximal median nerve entrapment or pronator syndrome, the pronator compression test involves manually compressing along the pronator teres muscle belly, or you can use again Tinel's sign by tapping along the course of the median nerve, or resisted flexion of the middle finger, PIP. Again, a positive test would be recreation of patient complaints. Finally, for radial tunnel syndrome or supinator syndrome, the Rule of 9 test can be used to try to discern the source of paresthesias. Pressure is applied to 9 areas denoted by circles. In the setting of median or radial nerve compression, pressure on the 3 medial circles, or 1, 2, and 3, should not reproduce symptoms. Pressure on the biceps tendon, the most proximal of the middle circles, or number 4, should be painful only in the setting of biceps tendinitis. Of the middle circles, pressure on the 2 most distal circles, or 5 and 6, may reproduce pain in the setting of pronator syndrome. The lateral circles, the 2 more proximal circles, i.e. 1 and 2, overlie the radial nerve. Because of the course of the PIN, pressure on the most distal lateral circle does not compress the radial nerve.